Good afternoon, everybody. Today we'll be discussing about hemostasis. Before that, I want to put on a statement like, why aren't you people died of a clot till now? Because the clotting factors, which is like all the clotting factors I have mentioned there, it is actually circulating throughout your blood right now. Then why haven't you died of a clot so far? So we have anti-clotting mechanism inside our body. So I'll be discussing that first. So consider this the epithelial inside the blood vessel. I have differentiated this thing. This is epithelial cells. Then this is collagens and all. Then this is smooth muscles. Okay. So in the epithelial cell will produce nitric oxide and prostaglandins. These nitric oxides and prostaglandins actually help your platelet, actually inhibit your platelet, and it will also cause the vasodilation. Kind of inactivate your platelet from aggregating together. Then you have heparin sulfate in these epithelial cells. So the floating antithrombin 3 will get attached to the heparin, and this antithrombin 3 will then inactivate these factors which is floating in your blood. Then you have thrombomodulin. As the name suggests, thrombin is a clotting factor, but thrombomodulin modifies the clotting factor and it will act as an anticoagulant. So to the thrombin, protein C will get attached. So where this protein C comes from? It comes from the liver, which is actually metabolized and made by the vitamin K. It is a vitamin K dependent factor. So protein, first S will be there from vitamin K. Protein S will be formed. Then it will go to proteins, will become protein C. Then this protein C will come and attach to the thrombin. When it is attached to the thrombin, it will become activated protein C. So this activated protein C will inactivate the factor 5 and 8. So this is how your blood is maintaining its own fluidity. Now there is something which hinders this fluidity. This is the virtuous triad. So according to virtuous, it's like either it is because of stasis or a hypercoagulability of the blood or an injury. So stasis, how can a person get a stasis or like venous stasis? Any idea? Yeah, for example, yeah, if you're sitting for a prolonged period of time, if you're standing for a prolonged period of time, usually the blood from the leg will come back to the heart. It is how it normally works, but now the backflow is not happening, so there is a stasis. Stasis means stoppage of the blood, or the blood pooling also, you can say blood pooling. So that's why you can see when the patient is not mobility, is bedridden patients, will give heparin because they are not moving much. So the blood flow back to the heart is hindered there. So there is a chance for the clot formation. Then there is a hypercoagulability that is can be due to age. All those factors will contribute. Again, genetic factors, if there is any genetic mutations, then it is the blood itself is actually prone to clot if there is a genetic issues. So the hypercoagulability can also contribute to the clot formation. Then comes the vascular injury. If there is a vascular injury, then there is a chance for the clot formation. Either two factors together can cause the clot formation. Either two factors. If it is stasis or vascular injury, together they can cause, these two can together cause the clot formation. Now we'll see how the clots are formed. For that, basically there is 5 steps. Actually, you can cut down the step. I just mentioned it. There is 4 steps, main 4 steps. First, after a vascular injury, I'm taking vascular injury. So after vascular injury, first thing happening is vascular spasm. Then it will be followed by the platelet plug formation, then coagulation cascade, then clot retraction and repair. You have to repair the injury, right? So the clot retraction repair, then removal of the clot. The clot, anything that is too much is not good for you. So we have to remove the clot. So first we'll go to the vascular spasm. So there is an injury. When there is an injury from endothelium will get released. Okay, this endothelium actually stimulate the smooth muscles. There will be a receptor in the smooth muscle. The endothelium will stimulate the smooth muscles. Thereby, there is a constriction of the smooth muscle. Okay, there will be a constriction of smooth muscle constriction. Okay, thereby it will constrict the vessels. Then you have myogenic mechanism. That is when there is a direct injury to the smooth muscle. So a mechanism from itself, that is myogenic mechanism, will get activated. Then it will cause the smooth muscle contraction. Then we have the pain receptors. So when there is an injury, automatically anti-inflammatory chemicals will be getting released, like prostaglandins and all. This will actually stimulate the pain receptor. But how it will actually act for contribute to the smooth muscle contraction means this process intact and will go and stimulate the smooth muscle, and it will cause the smooth muscle contraction. Why the smooth muscle contraction is important means to avoid much blood loss. The vessel itself constricts. Then comes the platelet plug formation. So when there is a epithelial injury, the collagen is getting exposed, and that collagen will be having the von Willebrand factor. That is von Willebrand factor. Platelets love this factor. So the platelets will come and get attached to the von Willebrand factor through the glycoprotein 1P. That is GP1P in short. So this will get attached to the von Willebrand factor, but okay, if there is an injury, 1, 2, 3, that whole space is covered. That is not enough. We need more platelets to actually block the blood flow, like the blood loss. So how the platelets will actually activate the other platelets? We'll see that first. The platelets will get attached to one another with the GP2B3A protein. But something will act as a glue in between. Can anybody say? Fibrinogen. So the fibrinogen will act as a glue in between the platelet bonding, and the platelet will aggregate together. So before that, we'll see how the platelet will activate one another. Then, when there is a injury, and when after the binding of the first platelet to the von Willebrand factor, there will be the release of ADP, then 5-HT. Do you know what is 5-HT? Serotonin. Serotonin will be getting released. Thromboxane A2 from the phospholipids of the platelet, it will get released. I'll talk about it in detail, but for now, just remember these things are getting released. Okay. This is another platelet. This is a platelet. This whole square is a platelet. So in a platelet, we have the thromboxane A2 receptor. So the released thromboxane from the first platelet is going and attached to the thromboxane A2 receptor. So it will activate a GQ pathway. This GQ pathway, you will be having two main functions. It will actually stimulate the endoplasmic reticulum, and it will release the calcium. This calcium will stimulate the alpha granules in that platelet, which will cause the release of again these things from this platelet. Okay, then we have the GQ pathway. I have not mentioned in detail. When I'll be taking the antiplatelet, I'll take it in detail. But it will stimulate the production, production of GP2B and 3A, which is responsible for the attachment of the platelets. Okay, so this will be formed. Then again there is ADP. So ADP also has two pathways. Same, like a GQ pathway is there, it will work the same. It will stimulate the formation of the GP2B and 3A, which will help for the attachment. But it is having another action, that is G inhibitory pathway is there. So how that exactly works is, in a platelet, we have adeno AC enzymes, okay. So this AC enzyme's role is that it will convert the ATP to cyclic AMP. Cyclic AMP will give that PK, will turn to PK, and it will phosphorylate the conversion of WASP to WASP-P. So WASP-P is active. Okay, this is inactive. inactive, and this is active. Okay. Usually it will convert to the inactivate form. It has no use, it will be stay there only. But when this is inhibited, okay, when this is inhibited, we have the active VASP. The VASP will actually stimulate the formation of GP2B and 3A. So when the ADP is binding to the ADP like a P2Y12 receptor, it will activate the G1 pathway. It will inhibit the process of AC enzyme, which will actually cause the conversion of ATP to cyclic AMP, and the VASP, this action will not happen. It won't convert the ATP to cyclic AMP, so that the VASP will remain active. When the VASP is remaining active, it will form the GP2B3A proteins responsible for the attachment. So we have to inhibit this pathway in order to keep the VASP active, so that we'll have the GP2B for the attachment. Am I clear? It's okay. Now we'll come to the coagulation part. We have the platelet aggregation because platelets has aggregated together. Now we'll have the coagulation cascade. So in the coagulation cascade, we have several factors, which is usually comes from the liver. It is also it's a cymogen which is coming from the liver. So it will be floating around. The factors, inactive factors will be floating around in the blood. We need to activate it one another so that it will follow a series of things. So the first thing will be getting activated is factor 12. It will get activated to factor 12A. The A stands for activation. So factor 12A will then activate factor 11. Factor 11 in conjugation with the calcium, it will activate factor 9, and factor 9 will be activating the factor 10. From here it is a common pathway. We have intrinsic and we have extrinsic coagulation pathways. So this is the intrinsic pathway I am mentioning. So here factor 8, activated factor 8 plus calcium plus 9A will activate the factor 10. Okay. So factor 10 then converts the factor 2 to factor 2A. Can anybody say what is factor 2? It's called prothrombin, and this is thrombin. This is activated form. Okay, the thrombin will activate factor 1 to factor 1A. What is factor 1? Fibrinogen, and the factor 1A is activated is fibrin. So fibrin, okay, fibrinogen will be imagine it's like a scattered fibrins. So fibrin will be like a conducted way. Okay. So here then the factor 13 will be getting activated by the thrombin. Then the factor 13 and calcium plus factor 1A, that is fibrin, together they will form a stable fibrin clot. It will be cross-linking with each other. Like if it is like this, one fibrin is there, it will cross-link with each other and it will cause a fibrin mesh. So this fibrin mesh will be formed here above the platelet, so that it can stabilize the platelet until the recovery. So here the fibrin clot is formed, it has stabilized. Now comes the repair. If there was a endothelial injury, it will repair that also. If there is a collagenal repair, it will repair that. Then if there is a direct injury to the smooth muscle, it will rejuvenate and it will repair that. Now after the repairing, we have the clot here, right? We don't need the clot. We have to remove the clot as soon as possible. For that comes the fibrinolysis. Otherwise this clot will go and block any arteries or any in leg. It can cause DVT, in brain stroke. So we have to remove the clot as soon as possible. So the fibrinolysis, the plasminogen comes from the liver. Again, it is a cymogen which is coming from the liver, and it will be converted to plasmin by the tissue plasmin activator, or the 12A or 11A. it can be converted, but it will take a few days. It will be happening simultaneously, but this activation take a few days. If it is happening simultaneously, means like simultaneously if plasmin is getting made or it is made, then we can't maintain the clot, right? We can't rejuvenate. So it will take a few days for the conversion of plasminogen to the plasmin. So the plasmin will actually, this is the same mechanism I have mentioned, not in detail, but in a simple way. The prothrombin is converted to thrombin. Then it will convert the fibrin. Okay, and it will in conjugation with the 13A and calcium, it will form a stable fibrin clot. Then the action of plasmin comes here. The fibrin is getting degraded into the fibrinogen is getting degraded into the fibrinogen degradation products, and the fibrin is getting degraded into the fibrin degradation products. The plasmin will degrade these things. And can anybody say how it will be getting excreted? Anyhow it degraded, but how it will get excreted out of the body? It will be getting excreted out through liver and kidney. So the kidney and the liver will clear out the clot. But again, we have one more question. There is a stabilized clot, right? The plasmin will degrade it into the fibrin degradation product. So we'll test it, like to check whether there is a clot, whether there was a clot. We'll check one test, D-dimer. So the stabilized clot will be getting converted to the D-dimer by the plasmin. So the test will reveal whether the patient had a clot or the patient is prone to have a clot or something like that. Then if it is more, I have already told anything too much is bad. So we need a break for the plasmin. If the plasmin is continuing its action, the blood will become hypocoagulable. So we need a break for the plasmin. It comes from the liver itself, that is alpha to antiplasmin and alpha to microglobulin. Thereby it will prevent the plasmin's action. It will remove the plasmin also. Again it will come back to here. That is again now normal homeostasis has maintained. So it will continue with this mechanism, like nitric oxide and prostacyclins will be getting released from the epithelial cells, and the thrombin will get attached to the thrombomodulin. Thrombomodulin modifies the thrombin, and the protein C, which is coming from the liver, will be getting attached to the thrombin and inactivates the factor 5 and 8, which is helpful in the coagulation cascade. Then heparin sulfate is there, so antithrombin is the hero actually here, so it will get attached to the heparin sulfate and it will inactivate factor 2, 10 and 9, so that the coagulation is not happening and remain the normal fluidity of the blood. This is the hemostasis and normal physiology. Any doubts?